Welcome to our Facebook Live. It is Greg Carpenter from CBS Radio. Today's 101.9, do the morning show with Gina Crash. And we're here with GBMC on our Facebook Live page and Dr. Diana Whitehead, gastroenterologist, board certified internal medicine and gastroenterology, right?
Enterology.
Enterology. See, I tried my best. So today we're really talking about Crohn's and colitis. And if at any point during our Facebook Live you have questions, we would love to hear your questions because it's all about us giving you information and then you reacting to us as well. So any questions, you can post them at the bottom of the page, of course, where the comment section is. Or if you feel a little, this might be a little bit private or so, you can send us a private message through GBMC and our Facebook Live. So I guess we really start out with what is Crohn's and colitis, because you hear people say, well, I've got some symptoms here and this, but then it comes down to really having Crohn's and colitis. What is it first?
Great question. So Crohn's disease, or Crohn's and colitis, I know a lot of people get the terminology a little confused. Crohn's disease is a different entity. Ulcerative colitis is also a different entity, but they are under the same umbrella of inflammatory bowel disease. So Crohn's disease is anything that it's a chronic inflammation and affect anywhere from the mouth to the anus. And then ulcerative colitis just affect the large bowel. So anywhere from the rectum to the large bowel, which we call the colon. So they fall under the inflammatory bowel disease category.
Sure. So you see things from the entire system, but then also things get isolated as well. Now, and I'm a novice, so I don't know anything that I'm talking about. So that does include the esophagus, into the stomach, and I guess small intestine.
Yes.
And then the larger intestine.
Yes.
Yeah.
So Crohn's disease specifically from mouth, so all the way down the GI tract, from the esophagus, the stomach, the small bowel, the large colon. So you got it just like that. And then ulcerative colitis or colitis just affects the large bowel.
Sure.
So it's just the large intestines.
And what are symptoms? You know, as we have our dinner or regular food or our weekly lifestyle happens, you're like, ooh, I don't really feel good today. But when do you go from not feeling well to I might have a problem here? Yeah,
that's a good question. So, you can have symptoms of bowel irritability. So, cramping, abdominal pain. Some people can have a little bit of irritable bowel. That's a little bit different. This is crampy abdominal pain, bloody stools, diarrhea. These patients are going anywhere from 10 to 15 bowel movements. It can be mild and from anywhere from mild to severe.
10 to 15 a day?
A day, like in a 24-hour period. That is mostly probably moderate to severe disease, but some patients may just have 4 bowel movements, but it's increasing in the frequency. The consistency will be looser. You have bloody stools. Some people don't have bloody stools. Some patients have weight loss. Other patients have other manifestations like fatigue, they're tired all the time, they have fevers, they have night sweats. So it's a constellation of symptoms, but certainly the run-of-the-mill abdominal pain can be also Crohn's disease that goes undiagnosed or ulcerative colitis that goes undiagnosed.
Well, how do you diagnose it? Like, you don't feel well, you have the symptoms, and then it gets real.
Yeah.
How do you diagnose it? I don't know anything about this.
Sure.
So when do you recognize that, okay, this is Crohn's or colitis, or is it both sometimes?
So it can be one or the other. Sometimes we can't decipher the two, but when you start to think, okay, something bad could be going on, you have fevers, you have weight loss, your appetite is decreased, and sometimes you may not have a lot of symptoms, but just abdominal pain. A lot of patients go undiagnosed for a while before we diagnose it, and to diagnose it is 3 criteria. It's clinical symptoms, the symptoms that we described, endoscopic imaging, so we use a colonoscopy or an endoscopy, an upper endoscopy. It's basically a long tube, it has a camera in the end, and we go through the mouth and esophagus and the stomach, and we also can go from the other end. And then we can see endoscopically specific findings, ulceration, inflammation. And then we take biopsies during our procedures, and then we send it off to the pathologist, and the pathologist looks at it. And through the clinical, endoscopical, and pathological diagnosis, we can put it together and say, yes, you have Crohn's disease, or yes, you have ulcerative colitis.
And these are procedures you really shouldn't be afraid of. I mean, I've had a colonoscopy before for, you know, I've got a family history of colon cancer, which is a different subject, but I know there's apprehension about these procedures, and we really shouldn't. I mean, it's health first, and worry about the other stuff later.
Absolutely. I mean, it is quite a simple procedure. You know, I tell my patients, it takes about 3 hours. The whole coming into the endoscopy suite, getting into the procedure room, doing the procedure, the whole, I call it a shebang, takes about 3 hours. But the procedure itself takes anywhere from 30 minutes to 45 minutes. You're completely asleep, so you don't feel anything, and then we, you know, do our procedure.
So, I'm laughing because I remember my procedure, and they did the anesthesia. And I mean, I don't remember everything that went on. I just remember going, whoa, that feels good.
And then you're gone.
And I was like, I mean, it was an experience because I've never really had that happen before.
Yeah, no, it's wonderful. I tell my patients the prepping, which is cleaning your colon, is the worst part, but the best part of the procedure is getting to take a really, really great nap. The anesthesiologist is there with us. They give you a drug, and you're out, and you don't even know what we're doing. And then we take pictures, and we show you, and we come over and talk to you at the end of the procedure just to let you know what we found, and then, and then we send it off to pathologists. And they look at it.
And get a real better analysis.
Yes, exactly. So the procedure itself is, a lot of patients get really apprehensive about it, but it really is a day-to-day thing that we do, and it's pretty easy. We talk you through it, and we make your experience quite lovely. And I love my staff at GBMC. They were just wonderful to work with. Yeah.
Again, if you have any questions at all, feel free to leave a comment at the bottom of the page on our Facebook Live. So now we have gone through the test. We figured out our symptoms. We've been diagnosed. We've gone through the scans, I guess you'd call them. But now it comes down to treatment. We figured out we've got something going on, and now we go to the next level. How does it get treated?
Very good question. So the treatment is quite it's quite complex in a sense that there's different stages of treatments. We have several medications that are coming out now for Crohn's disease, colitis. I mean, it is really exciting time to practice inflammatory bowel disease because there's so many different medications that we can use. The disease itself, it's an autoimmune phenomenon. Sorry, I have to backtrack a little bit, but it's an autoimmune phenomenon where your body is basically attacking your own tissue cells, and so it creates this chronic inflammation. So our whole point of treatment is to decrease that inflammation and keep your symptoms at bay so that you can live a healthy quality of life. So some of the treatments are targeted to decrease or suppress the immune system, and that can help with healing the colon, healing the intestinal tract, and then you can also feel better and do better. So mostly, I don't want to get into the specific of it, but it's basically decreasing your immune system to protect it and to heal itself.
Cassandra had sent in a question ahead of time. You know, what are some natural ways to help with colitis? You know, I guess there's all sorts of medicine and I guess surgery as well.
Yeah, absolutely.
But then if you want to try things naturally, what can you do? Good
question. So the natural question is huge in IBD, of course. We're now learning that your intestinal flora, which is the microbiota, it has something to do with it, good bacteria versus bad bacteria, and how you can promote good bacteria. Certainly probiotics can help. I tell my patients the natural is not going to fix your disease. We have to put you on conventional therapy, and then this could be an adjunct to our treatment. So adjunctive therapy like probiotics, we can use, you know, the specific probiotics that we have. We can use antibiotics sometimes in conjunction if there is a complication from the disease. Sorry, not antibiotics, but we can use something called Tumeric, which is a natural way. It's from coumarin. It's a spice, so it decreases inflammation. So sometimes patients take turmeric, and there's a great study that they just came out with for ulcerative colitis using turmeric.
I know you don't want to diagnose other things or treat other things, but is that natural thing good for other things as well? What's it called? Turmeric?
Turmeric.
Turmeric.
Yeah, like you get it from like curry, you know, like it's a type of spice.
And it's just good for you.
It's good for you. It's good because it decreases inflammation. So a lot of patients use it in like arthritic pains, and if you have joint joint pains.
Interesting.
So it is helpful for ulcerative colitis, actually. So natural ways, it's turmeric, which is a spice. You can certainly do meditation. You can, I believe in acupuncture, and all of this is to decrease the stress in your life, because stress can actually trigger some symptoms of the disease. So we use these as adjunctive therapy to conventional therapy, and I love talking about it. I think you should talk to your gastroenterologist about it, to incorporate these natural ways.
And that is key. You might find a lot of tips and so forth here today, but really talk with someone, especially, you know, you're available, GBMC. And if you have any questions, again, feel free to leave some comments or a question if you're interested today. I'm curious, I had somebody who used to work here at the radio station, and I don't know if he had Crohn's or colitis. I don't know which one, but I know he was always focused on his diet. And what are some of the things that you should avoid or do if you're diagnosed? Good
question. So I tell my patients, you know, you're not going to eat anything that's going to cure the disease. However, you're eating a healthy diet is going to certainly help your colon and your intestinal tract. So foods that are high in fiber, of course, if you have a specific type of Crohn's disease in the small bowel, we always avoid high fiber diet.
So there's more than one type of disease?
So yeah, Crohn's disease and ulcerative colitis.
Okay.
Are under inflammatory bowel disease.
Okay.
Sorry.
No, that's my fault on that one.
Okay.
I was thinking that there are more than one type of Crohn's.
No.
Or something. Okay.
Well, yes, there is. Sorry. So there's different types depending on whether you have upper tract disease, which is the esophagus. So you can have stomach, you can have small bowel, and you can have colon.
Gotcha.
So it can affect anywhere, again, from the mouth to the anus, and there is different subsets of Crohn's colitis.
It's a lot to pay attention
to. It is.
So going back to the diet, you say high fiber.
High fiber.
Yeah.
High fiber, healthy foods. Of course, if you have a specific type of Crohn's disease that affects the small bowel and you have a narrow, and we try to tell you to stay away from the roughages because it can get hung up.
Really?
Yeah.
And well, I guess that makes sense. But you know, immediately when I say healthy foods, I go right to a salad, broccoli, vegetables, whatever.
Right.
But that might not necessarily be the right thing.
Exactly, depending on what type of Crohn's disease you have and what kind of complications you're having. And of course, if you don't feel well when you're having a flare, you know, avoid dairy, you know, avoid things that are gonna, you know, make you have increased bowel movements, such as high fiber, even though we tell you to eat a healthy diet. So
there, you say when you have a flare, there are good days versus bad days, and even though you're in continuous treatment, something could still happen?
Absolutely, and that's where you talk to your doctor. You know, we get you on a max. Our whole goal is to put you into remission, to make your good days outweigh your bad days. And so if you're having a lot of bad days, I think people get a new set normal and they kind of live with your symptoms, but we certainly should get you on treatment so that you can have better days and then you're not flaring. Because if you're flaring, then you avoid foods, you know, that are going to make you feel terrible. When you have a cold, don't eat a big pizza, or, you know, when you're not feeling well.
That's my trouble. Right.
Although it might be delicious, you know, you're going to pay for that later. So diet is certainly helpful, but it's not the mainstream of treatment. A healthy diet is great, but depending on what type of disease you have, it can also be bad.
And they say always just pace yourself. You know, don't overindulge. Don't you know? Always just keep a steady stream, sort of. You know. Now, kind of backtracking a little bit, and forgive me if you've already covered this, but this is something. Either of these diseases, or any type of the disease, something you'll always live with, won't you? It never really goes away.
That is very true. It is a chronic condition, and probably why I love to do it, because you do establish relationship with patients, and you know them for a long time. It is a chronic condition, you know, kind of like diabetes or hypertension. But we certainly treat it so that we can make, you know, improve your quality of life. But yes, it's a chronic condition. We can't take it away, but we can certainly make you feel better with our interventions.
Again, thank you for joining us on our Facebook Live with GBMC and Dr. Diana Whitehead. We are always encouraging your comments and questions at the bottom of our page. Feel free, let us know what's on your mind. You can also private message us as well if you'd like to. But so we're talking about this disease and having it for life. When you enter certain life stages, things change, like pregnancy. How does someone handle pregnancy during a situation?
That's a really good question. It's a really hot topic now in the inflammatory bowel disease world with pregnancy. Well, we know from our studies that pregnancy, if your disease is in control, you don't have a decreased chance of your fertility is the same as somebody who does not have inflammatory bowel disease if your disease is in control. The problem comes when your disease is not in control, and certainly that can increase your risk of, there is a question of preterm labor or miscarriages or all of that. Again, it's all about getting your disease in control before you get pregnant. And your chances of getting pregnant it's the same as the general population. It's just that we have to pay a little bit more attention and make sure you are in remission so that you can carry a healthy full-term pregnancy.
Once you're pregnant, right?
Yeah. And we care, patients have ulcerative colitis or Crohn's disease, get pregnant, they're on medications through their pregnancy, and they do well. And we want you to be on your medicines. Of course, specific type of medicines we pull back from, but the biologics is what we're using for severe diseases. We keep patients on it through pregnancy, and the data supports that. And the patients and the fetus or the child does really well.
What age is this mostly diagnosed? Is this a young disease? Is it middle age? Do not only older people, mostly older people get it?
Good question. There's a bimodal distribution, meaning that younger patients get it. So we're seeing Crohn's disease as young as 10 years old.
No kidding.
And they're getting younger and younger, and maybe the dynamic of the disease is changing, and we know that for sure. So we certainly see it in the young, and normally around the college age is where most people get diagnosed. And then we don't see it in the 30s or the 40s. We see it again in the 50s and the 60s. So there's almost like two humps where you see in the very young and kind of the 50s and 60s. I don't think those people are old, That's the new 40, the 50s
absolutely.
and 60s.
Maybe even 30 or 25.
Those are the two populations that we see.
Now, is it hereditary, or is it all about lifestyle and diet? How do you get it?
Another good questions. We actually don't know, and in medicine we don't know a lot of things, but the things that we do know is that it's autoimmune, meaning that your body for somehow just triggers a system, and your immune system is supposed to protect you from viruses and bacteria, but then all of a sudden your systems start to attack your own tissues, and then that creates a chronic inflammation. We know that there's a genetic component, so it runs in families, and it's normally seen in Jews of European descent, but also African American and Hispanic communities. We do see it. The male and equal distribution is the same, but certainly genetics is a big component. So if your sibling has it or your child has it, your chances of it passing on, it's prevalent in the general population. And if your parent have it, your risk also goes up. If two parents have it, that risk even gets higher.
Really increases.
So there is genetic component. There is the autoimmune phenomenon that's triggered, and then there's
just your body.
Just your body, and then there's also environmental triggers, and we're seeing that maybe there's something in our diet that's triggering it, and changing the microflora in our gut, that is making the bad bacteria grow more, and the protective bacteria go down. So there is some microbiota, flora changing, and all those three components are part of it. And we're just learning more and more about it.
Still so new, you're getting a lot of education yourself.
Yes.
So you feel bad, you get diagnosed. We come to GBMC. What kind of treatments can we get at GBMC?
We offer great treatments. We have a great IBD program that we're building right now. We have an IBD infusion nurse, so we do, some of the medications are infused through the IV. So they come right into our office. You see a physician there as well, but there's also an infusion center so the patients can be comfortable and get their infusions there. We have a great resource with Geckel Center with our nutritional services, and they are helpful to help us kind of do education about diet as well. We also have a great colorectal surgeons that we refer patients to, because sometimes conventional therapy is not medical therapy is not sufficient, and you might need surgery. So we certainly have the surgeons that can help us. We have oncology as well, and then of course our GBMC Gastroenterology. There's 7 of us actually. I misspoke. We just are growing.
That's That's good.
This is really good. And we do IBD, and we're trying to do a comprehensive approach to inflammatory bowel disease, and that's what we're gearing for. We have our endoscopy suite, so we also do endoscopies, upper endoscopies, capsule studies. So we do it all.
It is a good system there. That's great. We do have a question and comment from Facebook. Mindy is with us to give the question.
So this question comes from an internist, and she says, we always struggle about diagnosing a Crohn's or ulcerative colitis flare-up versus infection. Should we start ABT versus steroid, and how should we manage a patient that is admitted with a suspected flare?
That's a good question. And ABT, can they elaborate on the acronym?
I'll ask her.
You're asking, okay. So
that's the best part about Facebook. It's really interactive. We can go back and forth.
So it is a very good question. So with patients with inflammatory bowel diseases, we know they do get susceptibility to infection. So sometimes it's hard to decipher whether it is related to infection or this is a flare, but an infection can certainly trigger a flare. So first, we should certainly get stool cultures. We should get specifically C. difficile, which is a huge, bacteria that we see in patients with inflammatory bowel disease. So get your stool cultures, get C. diff, and certainly treat the patient as if they have an infection. And then once your stool cultures come back, you can certainly start them on, IV steroids, but certainly always rule out infection. But know that infection can trigger an underlying flare.
I wanted to clarify. ABT, I am not a doctor, and I don't play with on TV, I promise.
Neither am I.
ABT is antibiotic. So.
Oh, antibiotics, yes.
So we learned something.
It's funny, like everybody has different acronyms. I would say ABX, so you can certainly use antibiotics and make sure they don't have an infection. And then start antibiotics, and there is some data for Cipro and Flagyl initially when somebody comes in with an acute flare.
I'm just a DJ. I don't know what all that stuff just meant. So we do appreciate the comments and questions, and you can keep them coming. We'd love to hear from you. Facebook Live, the comments down and questions down at the bottom of the page, or if you want to private message us, you can do that as well. I'm kind of curious, sometimes with diseases, they lead from one to another. Will Crohn's and colitis, or either or? I never really know how to approach it. Is it Crohn's and or colitis, or will it affect other things? I hear something about psoriasis and.
Yeah, that's a good question.
So I guess my question is, does one affect the other? Does one create the other?
Good question. Good question. So they're certainly, these are all part of the autoimmune diseases. And with Crohn's disease or ulcerative colitis or colitis, you can see something called extra intestinal manifestation. So they're outside of the intestinal tract. And certainly you can get inflammation in the eyes. You can get inflammation of the joints. You can get even skin manifestation. It can affect your liver. It can affect your kidneys. And some people have psoriasis component, as you mentioned, not because it causes it, but it comes together. They are all part of linked. The autoimmune phenomenon. So certainly you can have extra, intestinal manifestations, and those are, this different organ system that I listed.
Sure, interesting.
Yeah, very interesting.
The human body amazes me, because one thing is linked to the other, and you have to really make sure to be careful of the other things that might pop up.
It is really, really interesting. Probably what makes me excited every day about medicine is there's so much. We are so intricate, and a little thing goes off, and then it sets off something else.
And it's always changing.
It is. It is always changing.
Yeah. Again, I appreciate you joining us for our Facebook Live with GBMC and Dr. Diana Whitehead. I guess I don't know if I have a lot of other questions other than the need. To me, if we're watching this Facebook Live and we feel like we might have an issue, what should we do first?
Absolutely. So talk to your doctor. And you can start with your internist. I believe in, I'm an internist before I became a specialist, and talk to your internist. If you think you have symptoms that are alarming or even concerned, certainly talk to your internist. They can send you, or you can give us a call at GBMC Gastroenterology. Our phone number is, Mindy will probably put it on Facebook for you, and we're happy to take care of you. I mean, we're a really good team that we work together, and we're certainly here to help if you feel like you need some help. help. Yeah, we're
that's
here.
good.
Yeah.
And you do have another question from
We
our
do.
Facebook Live.
Yes, that's actually the same internist that posted the other question.
I love the back and forth.
Yes.
She says, when do you go straight to Remicade as a treatment?
Very good question. So we're now starting to find out that step up and then you step down is a little bit better than going from top down or top bottom up.
Now, what does that mean exactly?
I know.
Yeah.
So medicine. So we have different stages of treatment, and the biologics are probably on the top tier of treatments. They are the Remicade or Humira or Cimzia, and we certainly use those for patients that have pretty moderate to severe disease. And we know from our data that if we start them on a top heavy drug, they tend to do better than going from bottom up, where you start with the more low dose, and
you just want to attack it.
You want to attack
Go.
it,
Yeah.
go, and then there's a good window period that we have to treat patients and get them well. And if you get them on a good drug initially, if they have moderate to severe disease, get them on a good drug, and a biologic like Remicade is a great drug for it. So, if a patient, for your question, has moderate to severe disease, and they're admitted, and you need to rescue their colon, giving them IV steroids, and you put them into remission. Get them on a biologic, and hit them hard first, but just get them on treatment. But of course, get your help of your gastroenterologist to help you with that. But certainly, top down is the new approach.
Do
you have another question?
Yeah.
We do.
Yeah.
It'll probably be our last question before we wrap up. And Stephanie asks, what group or practice are you part of? So
there you go.
Yeah.
Do a little shout out to your
Absolutely. I'm always about the shout outs. So yes, we practice at GBMC. We are at 65 North Charles Street with Suite 512. And we're part of GBMC. We're employed by the hospital, and so we're GBMC Gastroenterology, and there's 5 physicians and 2 nurse practitioners and a whole team behind us. And so that's where we're at. Yeah, if you need to reach us.
That's fantastic.
Yeah.
We really do appreciate you joining us on our Facebook Live. Here's the best part of what I think the Facebook Live is. We change them all the time. There are always new topics, new things to learn, and if you have an issue, you might learn something about yourself at the same time. So always check in GBMC's Facebook Live segments with CBS Radio. Thank you very much. Thank you very much for joining us.
Thank you. It was a pleasure. Thanks for having me.